Good evening, everybody, and very warm welcome to the 14th Annual History of Medicine and Public Health Night at the New York Academy of Medicine. Uh, we're more than happy to have you here, and I will ask Paul Thurman to make some remarks to begin with. Paul?
Thank you, Bob, and good evening. I'm Paul Thurman. I'm the director of the Academy Library and its Center for the History of Medicine and Public Health. As a historical medical library, for many years, we have partnered with and supported the work of NYAM Section on the history of medicine and public health, providing the materials and the services that foster good historical work. Tonight, we're going to hear 5 excellent presenters, and we will profit from their efforts. I'm very much looking forward to this evening's program, and I'm glad that you've decided to join us. Before we start, I'd like to give you a short introduction to the Academy and to the library. The New York Academy of Medicine was founded in 1847, and we are now 176 years young. Today, NYAM is happy to take on the mantle of champion of health equity. We are a leading voice for innovation in public health, tackling the barriers that prevent everyone from living a healthy life. The Academy Library dates from the very beginning of NYAM. We have since grown into one of the most significant collections in the history of medicine and public health in the country, with books including an extensive collection of rare books, journals, pamphlets, illustrations, manuscripts, and archives from around the world and across the centuries. We're quite proud that the web publication Secret NYC just named us as one of the 10 most beautiful and best libraries in New York City. We invite you to connect with us both digitally and in person. To learn more, go to the library page on the NYAM website. I especially invite you to follow us on social media, Facebook, Instagram, and Twitter. Just search for NYAM History, all one word, on those platforms. To visit us in person, join one of our drop-in tours on the first Monday of the month at noon. The next one is indeed next week. I'd like to let you know 2 further things. You may turn on closed captioning for this event, and you can pose questions for our speakers in the Zoom chat feature, which we'll address after each presentation. I very much look forward to hearing what everyone has to say. Finally, please be on the lookout for a note announcing the video of tonight's event. I hope you will join us for future NYAM offerings as we seek to understand and address the challenges that prevent everyone from living a healthy life. Thank you. And now I pass the podium back to Dr. Rubin, who will introduce our first speaker.
Thank you very much, Paul. It gives me really great pleasure and privilege to present our first speaker, Christopher Aids, an amateur historian, not so amateur, and the title of his presentation this evening is In Sanitary Communication, Yellow Fever Outbreaks as quotes, local unquotes, epidemics. Take it away, Chris.
Thank you for this opportunity to share in this forum. In my presentation, In Sanitary Communication, Yellow Fever Outbreaks as Local Epidemics, I would like to share why I believe yellow fever, by the very nature of the disease itself, merits smaller scale and even local historical study. In my own work, an ongoing study of the 1855 yellow fever epidemic in Norfolk and Portsmouth, Virginia, I have been strongly influenced by John Burnham's 2005 book, What is Medical History? I will review Burnham's book briefly and then discuss how this has shaped my own work. But I want to start by asking and answering the question, what is local and how that might be defined when looking at yellow fever? Henry Rose Carter, in his posthumously published work, Yellow Fever, an epidemiological and historical study of its place of origin, described community as the people who are in sanitary communication with each other. He further recognized that in an endemic zone where yellow fever occurred annually, native residents were more likely to have been exposed to the virus previously, perhaps in childhood, and were therefore likely immune as adults. The hotels and lodging houses mentioned in the quote above were more likely to be inhabited by strangers who were from outside the area who were unlikely to have previously acquired immunity. One side note, the term sanitary is sometimes misleading in these sorts of publications. In more common parlance, this term sounds like it is about waste-related issues, which sometimes contributes to confusion about the role of filth, in quotation marks, in discussions of yellow fever events historically. The yellow fever, just as a reminder, is not spread through waste like cholera or typhoid. Let us now look at Burnham's model and see the framework it provides for a deeper investigation. John Burnham's book, What is Medical History, was published in 2005. His approach in this book is sweeping in scope as he explores the many areas which could be considered influential on medical history. And it is intentionally written to show the breadth of both the question and its potential answer. Burnham presents 5 dramas or characteristics of medical history. I've reordered the dramas from Burnham's original to suit my own purpose, and actually believe my preferred order, which is given on the slide, I think is better than Burnham's. I will briefly consider each of the 5, emphasizing the aspects of each of the dramas that have been most helpful to my thinking. First one, society. Burnham, sort of summarizing this, Burnham says, environments, disease patterns, political, economic, and societal responses to changes in people's health status all have been in dynamic interchange throughout history. In my own work, I have expanded this drama by my reading in geography on the concept of translocality, which provides a model on the study of interconnections and intersections in specific locales. My thinking has also been influenced by actor network theory from the field of sociology, which encourages the consideration of the influences of both people and things, both animate and inanimate, in the study of any event. Moving on, Burnham's presentation of disease is pretty straightforward: etiology, nosology, epidemiology, and pathology, the cause, the classification, the incidence, distribution, and control, and the effects of a disease. When discussing epidemics, Burnham mentions the need to keep in mind how the disease was understood at the specific time under consideration, and cautions against the error of presentism, expecting to see today's understanding in the past, and also of retrospective diagnoses, trying to determine which medical cases in the historic record were really yellow fever in this case and which were not. It's important to remember the CDC lists over 20 diseases that should be considered in doing differential diagnosis of possible yellow fever patients. And the World Health Organization notes, quote, a more severe case can be confused with severe malaria, leptospirosis, viral hepatitis, other hemorrhagic fevers, infection with other flaviviruses, such as dengue fever, and even poisoning. Returning to Henry Carter's work, he emphasized that yellow fever outbreaks require 3 things to both begin and to continue. He referred to these as conditions requisite for the continued existence of yellow fever. Those are the virus itself, the vector, Aedes aegypti primarily, and susceptible victims. While other species of mosquito can transmit the virus, the Aedes aegypti is the primary urban transmitter, and I consider it the most likely vector in the specific epidemic that I'm looking at in Norfolk and Portsmouth in 1855. The interplay of these three prerequisites continue to appear in studies of especially yellow fever modeling, where they look at the presence, trying to track and project the presence of the virus, the vector, and then anticipate sort of the victim load that's available to the virus. Burnham's next category, the sick, he calls it. I called it victims so that I'd have the alliterative thing of virus vector victims. Burnham notes that doctors' own narratives of their own treatments can sometimes give the most detailed descriptions of sickness. And this is true of the Norfolk and Portsmouth epidemic, where doctors who went through the epidemic as both caregivers and patients left accounts of what they experienced. But he also warns that the very personal nature of sickness should always be kept in mind, saying that a patient's experience can be, quote, so idiosyncratic that they're not necessarily helpful for the historian. This would actually apply just as much to doctors' understanding of their own sicknesses at the time as it would a layperson or a non-professional. The healer category, which Burnham actually placed first in his book, I've placed here at the end. Burnham has a clear bias towards orthodox medical practice, although he does mention other types of medical practice, generally called sectarians in medical history writings. He also mentions the role of non-physicians, but he refers to them as second-tier care providers, and specifically mentions nurses and midwives. In yellow fever epidemics, the role of nurses cannot be underestimated and presents an extra degree of complexity to the study of these events. Interestingly, his medical ceremony of diagnosis, prognosis, prescription, and billing does actually even appear during epidemics. You can find doctors' accounting books that they track all the patients they visit during the epidemic. His last of his 5 dramas was Discovering and Communicating Knowledge, which he specifically means is medical knowledge. Burnham said that this drama uncovers the, quote, fundamental mindsets that have assisted researchers in the past in developing useful insights. Here, Burnham emphasizes the influence of medical education and medical publications and discusses how theories developed and evolved over time and how those theories then changed medical practice. So there's a real interplay between the healer category or the drama and this discovering and communicating medical knowledge. So this is a summary or an outline of some of the issues and questions that have arisen as I continue my exploration of this local epidemic in Norfolk and Portsmouth in 1855. In the society category, I ask, what was the specific role of the nation's largest naval base at Norfolk, both during the epidemic and in the recovery period afterwards? There was both a naval and a marine hospital located in Norfolk at this time. The role of Roman Catholic institutions is interesting in this. There were nurses, nuns, and priests who went to the site from other areas. So they worked both as care providers, and they also played an active role in managing the problem of newly orphaned children in the years after the epidemic's end. And there's also the question of what role did the local Black population, both enslaved and free, play in the epidemic? How did this community remember and memorialize the epidemic within their own community? In the disease category, my principal questions that I'm pursuing: how did the disease come to the area, and why did it spread and turn into an epidemic this particular year? Most years there were yellow fever patients at the Naval Hospital, so the virus was in the area pretty much every year. I also wonder what might local public works projects have contributed to higher mosquito populations. And specifically, there are 2 large cistern projects, each 35,000 gallons of water, built on the naval base in 1851 and 52. And it's curious to think that they may have contributed to the mosquito population in a way that helped make the epidemic occur. In the victims category, one of my goals in this local research is to identify and understand some of the victims better. It's actually a daunting task as you dig into it. There would likely have been about 8,000 infections, and then there were approximately 2,800 deaths over the 4 months of the epidemic. A quote from a Catholic publication at this time exclaimed, "Alas, how many familiar faces are sought for in vain." I I would also like to clear up some of the errors in the historical record if I can. Misdiagnosis and overdiagnosis are two of those, and clearing up inaccuracies in mortality schedules. Just as an aside, I like to mention that about 250 doctors went to the area during the epidemic between July and October of 1855, and about 50 of them died. So that'd be a 20% mortality rate. Such numbers for the nurses are harder to find because their names don't appear in the medical record as much. In the healer category, I like to remember what Dr. David Jones of Harvard University said at a 2018 NIH lecture, quote, "There's nothing innovative about making fun of what doctors have done in the past." And I use this just to remind myself that these healers during the epidemic situation did indeed face a daunting task. Questions about therapeutic models, how they changed through the course of the epidemic as different doctors came in who had different educational backgrounds. What was the role of non-physician care providers? What did they experience? I've not been able to find any record of that. Lastly, in the knowledge category, largely looking at educational backgrounds, it's interesting that there's about half of the doctors who participate as care providers went to the University of Pennsylvania. And I want to explore what that may have meant to them as care providers. And also had doctors who came from southern states like Louisiana, what they would have brought to the epidemic that would not have already been present there at the time. Burnham said, "The past was not only complicated, but different, often very different from the present. Knowing about these differences can bring great wisdom to later investigators and to other readers of medical history." And he noted that a more focused investigation can serve to bring distant time near so that we can examine general points more clearly. I would hope that Burnham's model might inspire other researchers to dive deeper into lesser known local yellow fever outbreaks in mid-19th century America. Baltimore in 1819, Savannah, Georgia in 1820 and 54, Charleston, South Carolina in 1854 and 58 are all good examples. And through this, they might enrich our appreciation of the men and women who struggled against this disease, sometimes at the cost of their very lives. Thank you.
Thank you very much, Chris, for fascinating. There's no questions in the chat. However, it was much richness in what you gave. How do you feel this related, what happened in the yellow fever in Portsmouth and other places, with what happened in the early stages of COVID here in the United States?
Actually, someone online was having a discussion about this, and I usually don't participate in online discussions, but I said that I thought the understanding of what was happening with COVID was really kind of skewed because of the insistence on talking about stuff in really broad geographic ranges. And so you would end up losing the sense that, my community could have a pretty bad outbreak, but if you just look at the broad numbers, but it actually could have occurred in one large event or a couple of large events. And so the example I used for this on this online thing was I just suggested that a city like Bristol, Virginia, which is also in the state of Tennessee. So there's Bristol, Virginia, and Bristol, Tennessee. It would be interesting for someone to look at those two to see how different their numbers probably are just because of the way the statistics were tracked by the state. I think that appreciation for the complexity of how numbers are gathered and numbers are interpreted during healthcare emergencies like an epidemic, really, we saw that happen again with COVID, and it really wasn't that much different than what we saw during COVID.
It's interesting, when you looked at the mortality, you said about 10,000 cases, of which about 2,600 died. That's the same as physicians, 1/4.
Mm-hmm.
Really, thank you very much, Chris. And I think we now will move on to our next presentation by Danae Brown, who is an independent scholar of True Resource Use and Efficiency Zero Waste Certification Program and she is a recidivist with us, having presented some years before. Are we lucky to have her again? Her presentation is entitled Climate Change and Epidemics. Go ahead, Danielle.
Thank you very much, Dr. Rubin, for my presentation. And thank you as well to the NYAM section on History of Medicine and Public Health for this opportunity to present. And thank you all in attendance. Again, my name is Danielle Marquis Brown. I am a multi-hyphenate working in the realms of design, the humanities, and sustainability. Let's touch upon a distinction between approach mainstream starts to account the what happened. Starts with a challenge, initiating a historical analysis, perspective, and gap insights to form trajectories to said current scenario. Search and applied exercise identifies the complicated dynamic climate crisis, public health as the challenge and starting point. Regarding think average weather over a period of time from months to years, so 30 years is the modern classical frame for use average, and changes in identifiable change human-made changes that continue to affect the composition of fear. A quick out of this.
Now, we're having a problem with the audio. It's breaking up severely.
Oh,
I'm
okay.
stop and see if we can't get it fixed, and I'll move on to the next because it.
Okay.
Okay.
Thank you.
That's. Hold on, I got all types of things happening here. Okay, it was breaking up. Let me just. Okay. Let's see where everybody is here.
Can you hear me better now, or is it?
That's good now. Yeah. What did you do differently?
I don't know, but
Okay.
I will try
Well,
again.
continue, okay? Yeah.
Okay.
We won't penalize your time. Go ahead.
All right. Thank you very much. So, like I was saying, is like lead certification. The certification program resides under the U.S. Group Council and is used to achieve zero goals, cut gaps, and support public.
You're breaking up again. When you sit back, your voice is don't lean forward. Something's happening. Sit back.
Okay.
Okay. Now keep on
Okay.
going.
Thank you. So this I released this month observes the 19th and 20th century data sets.
Oh, you're still breaking up.
I'm gonna. How about I pause and can we let? Do you hear me better now?
Yes, that's clear.
Okay. I'm gonna actually take off my headset just to see if that helps with. If you give me one moment.
Okay, go ahead.
Okay. So I'm gonna use a different microphone. That was probably the Bluetooth. That was probably the issue. I'll go back. Give me one moment. I'm just going to advance back to, okay, so here we are again. So this IPCC chart released this month observes 19th and 20th century data sets projecting onward from 2021, glaring the changes in the global surface temperature if we don't act now. And where this chart begins, my exercise concludes, spanning the 19th century. Here are some pivotal milestones pertaining to climate science represented as green circles and public health sanitation as orange circles. While exploring NYAM's library collection, I happened upon two standout works represented as the blue circles, which are hybrids of both. I'll refer to the first as The Climate of Great Britain by John Williams, Esquire, given the long title. Williams's background is not clear. I have gathered that he was a lawyer, scholar affiliated with the Merton College, focused on trade and commercial law. Yet this work is rooted in science, experiments, observations, histories, and hypotheses differing from his law-based work. It's evident he was well-read and appears he was an amateur meteorologist before it was established as a profession. In third person, this humble author prefaced, "His aim is truth and his only wish the furtherance of science." He continued, "He covets no praise, fears no blame, if at fair investigation it appears not to be substantially founded in the view of candid and scientific men." And in there's a 4-page in this book that says, "To Sir John Sinclair Bart, President of the Board of Agriculture, continuing who high distinguished rank among the men of science, especially those who have dedicated their science to the benefit of their country." Now, whether Williams knew Sir Sinclair or if this is an example of public activism of sorts is unclear, because Sir Sinclair, his name only appears once on this page. Throughout the 358 pages of this book, we occasionally are met with Williams' hypotheses such as the quantity of free thermometrical heat given out in the processes of combustion and animal respiration may have some influence on the atmosphere and cause an increase of temperature in winter. He also notes around 1770 or 1775, roughly 30 years prior to his publication, other weather observers became aware of these changes. Now, if you recall, the first industrial revolution, the dawn of the fossil fuel and modern Iron Age era, began around 1760 in Great Britain. Throughout Williams' book, though it emphasizes meteorology and the vegetable and animal economy, narratives on physiology and subjects of disease and epidemics appear throughout in the context of animals, planets, and human. Williams' aim is to show how these arts and sciences are intimately connected with the prevention of disease and the preservation of life. Never formally trained as a student of medicine, he displays familiarity with some ancient medical texts and figures. Although he does not name many, Williams singles out and gives particular reverence to Hygeia, the goddess of health, cleanliness, and sanitation, from whom the word hygiene is derived. Leaving the early 1800s and entering the 30s, seen as a growing awareness that good hygiene and sanitation are crucial to combat epidemics and infectious diseases. By 1838, lawyer turned social reformer Edwin Chadwick saw that change was needed, especially for the laboring poor. So he led a team of commissioners in 1842 and published the report on the sanitary condition of the laboring population of Great Britain. And here we have atop the NYAM's entrance, which depicts on the right, you have Eusipicles, the god of medicine, said father of Hygeia on the left, per the ancient Greek texts. And so, and here we have meanwhile, in 1847, a group of physicians gathered in NYC to advance the art and science of medicine and promote public health and medical education. And that's when NYAM was established. Its foundation eventually led to the first sanitation and public health departments in America. A year later, on the other side of the pond, Chadwick's efforts paid off and the Public Health Act was passed, in effect till 1894, establishing local boards of health in towns and popular places in England and Wales to improve sanitary conditions, excluding London. Mid-century, the Epidemiological Society of London was established in response to cholera epidemic in 1849. And so as the sanitary sciences gain prominence, we see the establishment of the Sanitary Institute of Great Britain in 1876, innovations in chemistry and microbiology, such as Louis Pasteur's 1877 work on chicken cholera and the anthrax affecting cattle. And as alluded to earlier, in 1881, the New York City Department of Street Cleaning later was named the Department of Sanitation in 1929. And so something interesting happens in the late 80s and early 1890s in the climate sciences. It's a short-lived moment, but this is realm of interdisciplinary community. And this is exemplified by the monthly journal, The Climatologist, which existed from 1891 till 1892, devoted to, quote, the study of climatology, mineral springs, diet, preventative medicine, race, occupation, life insurance, and sanitary science. 2 months after its premiere, Thomas George Hotchkiss, not to be confused with the physician Thomas Hotchkiss, who the Hotchkiss disease is named after, donated a large sum to the Smithsonian Institute in DC with the directive to increase and diffuse knowledge regarding connections between the atmosphere and welfare of man, whether in connection with hygiene, biological, or physical knowledge. And so we arrived to 1896, when The Atmosphere in Relation to Human Life and Health by Francis Albert Rollo Russell was published. Russell was an English meteorologist, a vice president of the Royal Meteorological Society, fellow of the Sanitary Institute of Great Britain, member of the Royal Institution of Great Britain, and a writer. This work was a submission to the Hotchkiss Fund Prize and was awarded honorable mention and a silver medal. Prior to the fund, Russell did author other health-related works, such as National Strategy Against Infection in 1888, a work on the spread of influenza in 1891, yet he had no formal medical training. Russell's most famed work is London's Fog, a pamphlet published in 1880 that inspired several aristocratic and upper middle class groups to advocate for cleaner gas heating as opposed to coal. Comparatively, as can be inferred by the title, The Atmosphere in Relation to Human Life and Health dives deeper into health narratives, whereas London Fogs leans more so into the meteorology. But this 1896 work does cover such narratives as well, even containing references to John Tyndall, who contemporary cultural memory assumes to be the father of climate science. Though he doesn't mention American scientist and women's rights activist Eunice Newton Foote, whose 1856 work precedes Tyndall's. And actually there's, that's up for debate as to why Tyndall did not mention her if he knew her, but that is another presentation. And so the only woman that Russell seems to mention in his work is one of two people he highlights as prominent individuals in the sanitary sciences, though it's not obvious. If unfamiliar with the history of nursing, he merely regards her as, quote, a distinguished lady, yet based upon the surrounding texts, we can infer he means Florence Nightingale, mother of modern nursing, social reformer, and statistician. During the era of, gendered politics, many referred to Miss Nightingale as the lady, and here's a painting on depicting her entitled The Lady and the Lamp. The second prominent figure Russell mentions and cites is, quote, Mr. Chadwick, the great sanitary reformer. Recall Sir Chadwick was he was the gentleman behind the 1842 report on sanitary conditions, and he and Miss Nightingale were allies. In addition to the, in addition to the sanitary sciences, Russell also roams in the building sciences, for instance, considering how bacteria and small organisms circulated in the buildings of public spaces, if not well ventilated. We can tell from his previous works in 1892 on epidemics, plagues, and fever that Russell was familiar with Louis Pasteur, and given Russell's independent studies on germ theory and how diseases spread, that further complemented his foundational work in the realms of meteorology. The diseases that he surveys for this prize entry represent only some studies. The Hotchkiss Fund was an opportunity for Russell to compile various subjects that he wrote upon prior for different audiences into a single body of work, enabling him to illuminate for a wider audience the interconnectivity of the various arts and sciences discussed. This work is not a mere copy and paste piece. There is nuance and it contains new elements, original subject matter, and ideas. For instance, an idea for a system of international warnings on the prevalence of epidemics. And so we're back to our current timeline in this exercise of applied history. And so in response to a 2021 US executive order, the Climate and Health Strategic Framework was created by the CDC and the Agency for Toxic Substances and Disease Registry. General consensus is here. Climate change poses a great threat to human health, the public. However, as historical analysis begins to render, as a collective, we must not lose sight of the role sanitation, hygiene, and waste play upon the health of individuals and the public. To conclude, I invite you to continue engaging in historical reflections as we face these current complex challenges now and ahead. And as history's unsung songs often remind us, some just resung again from different genres, innovations, solutions, and ideas exist and can be created in various places in and beyond silos. And a daily dose of inclusion and curiosity and camaraderie could do the global body good. And with that, I thank you for your attention.
Thank you very much, Daniel. We have one very interesting comment from Dr. Elizabeth Frost, and she says, the United Kingdom may continue to lead the way. In the last few months, Scotland, to be followed by England and Europe, has banned the use of popular anesthetic desflurane because its deleterious effect on the atmosphere. Desflurane is still widely used in the USA. You wish to comment on this?
So yeah, the UK and Europe are definitely ahead when it comes to many things in sustainability and waste management. And I have not heard about this particularly, but I will definitely look into it. I do recall there was a recent report, particularly for the medical community in general, specifically because of COVID and what is happening with the PPE and waste. More countries are becoming more aware of the roles that the medical community has in sustainability and waste. And so there was another question.
Next question. Do you think that the push for sanitation and sanitary conditions led to classicism against the poor?
So that is, it gets into a tricky debate. You start to see there was a different approach to sanitation around towards the end of the 19th century going into the earliest. And it has, even if you think about, I mean, Martin Luther, so before the realm of the medical community and Hygeia, for instance, being a goddess of sanitation was in one connotation, but then by the 1960s, you had Martin Luther King Jr. going to Tennessee, advocating for dignity and rights, and this when the waste and sanitation workers were on strike. And now you also too have issues in Paris, for instance. So it has evolved, but as Christopher had mentioned in his presentation, sanitation, our understanding of it gets a little bit dicey.
Thank you very, very much for really an excellent presentation, and I'm glad we got the audio straightened out. That is really good. Our next presentation is Irene Auteri, PhD, registered nurse, assistant professor at Delphi University College of Nursing and Public Health. And the title of her presentation is, Does the End Justify the Means? An historical analysis of Willowbrook School Hepatitis Study 1956 through 1971. Go ahead, Irene.
Thank you very much. Good evening, members of the New York Academy of Medicine. It's such a pleasure and honor to present this evening at the New York Academy of Medicine's 14th Annual History of Medicine and Public Health Night. When we study history, we study change. Change and history remain a classic dichotomy within the field of medicine, nursing, and social sciences. The dichotomy is important in the discourse of constructing and evaluating historical events. Studying medical history helps us understand and confront complex questions and dilemmas by examining how the past has shaped and continues to shape the medical community. The past teaches us about the future, teaches us about the present. In many ways, history deciphers previous events that contribute to our current world. Research today is based on historical elements of the past, which makes us a stronger society today. Okay, so my presentation, does the end justify the means? Mentally and physically handicapped children housed in the Willowbrook School located in Staten Island, New York, were intentionally given hepatitis to study the effects of the disease and given gamma globulin to some to note recovery efforts. The purpose of this examination is to deepen the understanding of informed consent, coercion, and the justification of research on vulnerable populations. Beginning with the Nuremberg Code, followed by the Declaration of Helsinki, and thereafter the Belmont Report, the protection of human subjects continues to be a priority among all healthcare professionals. Overcrowded, understaffed, and long forgotten, the Willowbrook School became a sea of infection and paradise for researchers all living within the shadows of society. Human research vulnerability has always challenged mankind, and we talk about research on prisoners, children, the disabled. And during World War II, Nazi doctors conducted cruel and inhumane experiments on people, which led to the Nuremberg Codes and federal guidelines. The United States and the world have witnessed unjustifiable research that has violated ethical standards. So by re-examining the Willowbrook School's hepatitis study of what some consider Machiavellian morality of the end justifies the means, will strengthen our knowledge and guide our treatment of vulnerable populations. And this examination will draw from traditional historical approaches that explored the events utilizing archival records and secondary sources that interpret data from historiographical literature. And this was the Willowbrook School, located in the Willowbrook section of Staten Island, on 350 acres of land. And it was in 1964 that the Verrazano Bridge was built, connecting the last borough to the city of New York. So in 1938, plans were drawn up for this facility for the intellectually disabled. Construction started in 1942, but instead of opening for its original purpose, it was converted into a U.S. Army hospital and named Halloran General Hospital after the late Colonel Paul Stacy Halloran. And it was also a post-World War II prisoner of war facility. After World War II, proposals were introduced to turn the site into the VA, but the New York Department of Mental Health decided let's go back to where it was originally planned, and the institution was named the Willowbrook State School. And by 1965, the Willowbrook State School housed over 6,000 intellectually disabled infants, children, and adults, despite having a maximum capacity of 4,000. And by that time, Senator Robert Kennedy toured the facility. He saw the overcrowding, he saw the living conditions, and he said, quote, "Living in filth and dirt, their clothing in rags, in rooms less comfortable and cheerful than the cages in which we put animals in a zoo," and offered a series of recommendations. And here are some pictures of the facility. And as you can see, multiple children were in cribs, and multiple children were in beds, two at least in one bed. So as funding decreased throughout the United States, more and more institutions closed, and those residents were transferred to Willowbrook. So there was overcrowding, poor hygiene, understaffed, underfunding. My research showed that there were 12,000 residents who actually died in the 30 years, which was about 400 per year. And there was neglect, violence, lack of nutrition. These were causes of death, medical mismanagement, questionable homicides, or residents just disappeared. And it truly was because of hepatitis was endemic in this facility. So what was the study, 1956 to 1978? Well, this state called upon Dr. Saul Krugman, who was an infectious disease specialist at NYU, and his colleagues to come. And they actually did this study, and they published a series of articles of infectious diseases at Willowbrook. And it was established that there were two types of hepatitis, infectious hepatitis and serum hepatitis. And Krugman and colleagues, their study showed there were different diseases caused by different viruses. Remember, there were over 300 million cases of liver disease around the world due to hepatitis at that time. Experiments included deliberately infecting children with body fluids, which were fecal material, from patients with hepatitis. The consent was given from the children's parents. The articles started coming in New England Journal of Medicine, and the first, it kind of tore up the medical community. There was an uproar. 1966, Henry Beecher was the first to criticize the study. He said artificial induction of hepatitis was carried out in an institution for mentally defective children in which a mild form of hepatitis was endemic. The parents gave consent for the intramuscular injection or oral administration of the virus, but nothing is said regarding what was told them concerning the appreciable hazards involved. Well, Dr. Krugman, during his study, he knew that the virus was responsible for hepatitis, and it did not have hosts outside of human beings. He was persuaded that these conditions were justified on the disease in humans, and his initial research was to study gamma globulin injections to determine whether they would protect the children from infections. And the injections did have a strong protective effect. New residents to the school were admitted to an isolated area of the hospital and were fed samples collected from other children, and subsequently the virus was tracked and symptoms were observed. As a result, it was established that hepatitis had two strains, A and B. A had a shorter incubation period and was more communicable, and B had a longer incubation period and was less communicable. And this was the consent, and the consent was 6 lines. We're studying the possibility of preventing epidemics of hepatitis on a new principle. Virus is introduced and gamma globulin given later to some so that either no attack or only a mild attack of hepatitis is expected to follow. This may give the children immunity against this disease for life. We should like to give your child this new form of prevention with the hope that it would afford protection. And the permission slip is enclosed. Letters in the Lancet of criticisms and defense started coming in. The issue included the vulnerability of the test subjects, the interference with informed consent, and the non-therapeutic nature of the experiment for their subjects. Bowlby said it is morally wrong to perform an experiment on either a normally or mentally retarded child when no benefit can result for that child. He also went on and said the institutionalized should not be used for human experimentation. Papworth said experimentation on children, even with parental informed consent, is illegal unless it is in the interest of the child. And according to one report, parents were told that the only way their child could be admitted to Willowbrook is through the hepatitis unit. And the criticisms went on. And then in 1986, Dr. Krugman and colleagues wrote an article and gave his defense. And he said, important identification of two distinct clinical epidemiologic and immunologic types of hepatitis A and B were made. The study demonstrated that hepatitis B infection is transmitted by intimate contact and oral as well as parental exposure, and demonstration that hepatitis B immunoglobulin is effective for the prevention of hepatitis B, and development of the first prototype inactivated hepatitis B vaccine. He also went on and said, since there were 80% chance of the children getting hepatitis at the facility, the new residents would have been exposed to the same strains of hepatitis anyway. Experimental subjects had a lower risk of complications since they were housed in a special unit where there was little danger of exposure to the diseases. And the experimental subjects were obtained with informed consent, and they had the chance of benefiting from the immunization. So, does the end justify the means, I ask you? The Willowbrook hepatitis study did divide the research community. The study's protocols remain shocking today. Children were intentionally injected with hepatitis to determine the effectiveness of gamma globulin injections in protecting against hepatitis. The research was based on the premise that infection with a mild form of a viral agent can induce immunity, and prior research had been successfully tested and produced favorable outcomes, especially with the development of vaccines. But Krugman's research and colleagues, his research with vulnerable children was different. And we looked at, we always, in research, we utilize our principles of ethics, autonomy, beneficence, non-maleficence. Was the Willowbrook consent an informed consent? Was it a form of coercion? Did it promote good? Was there no harm? Did we violate the Hippocratic Oath? Did we attempt to bring the greatest amount of benefit to as many people involved as possible? And was it fair to all involved? Were there equal entitlements and equal access to benefits? Thank you. These are my references. Any questions?
I really checked the chat, but I didn't see any questions. But whoops, here we go. This is a statement. As a faculty member of NYU's Department of Pediatrics, my immediate reaction to your title was, of course, the ends do not justify the means. Saul Krugman was a distinguished pediatric physician scientist, and our concepts of ethical research and informed consent continue to be involved. How would you comment on the ethics of the journal, including JAMA, which published the studies? Interesting question.
Yes. Yes, he was very well known. And
it was Colin Phone who asked this. Go ahead.
Thank you. Yes, he was very well known at NYU, and actually his son became a pediatric infectious disease physician, and his grandson. Yes, so your question is, what was the second part of the question? I don't see the chat.
The question is, how would you comment on the ethics of the journals, including JAMA, which published the studies?
Yes, so in the first response in the journal was from Dr. Krugman, who said, you didn't give me a chance to respond to my criticism, but yet you published letters to the editor and you didn't give me a chance. So I think everybody had some issues with it. And I think the following issue, Krugman and colleagues, and many of his colleagues responded. And it still stands today, does the end justify the means? It was a horrible way of getting hepatitis. The children did not have hepatitis going into the study. Was the informed consent, was it truly informed? Did it say the risks and the benefits? Was there do no harm? Was there a violation of ethical rules? I think a lot of questions remain today.
Two more comments. I'm going to read them. This is
Yeah.
from Harry Washington. The research did not utilize voluntary consent and violated both the Belmont Report and the Nuremberg Code tenets. Beneficence doesn't come into play as the benefits are far from guaranteed. And the other comment comes from Miriam Fisher. Major Adams described Willowbrook as a good center and just a few bad actors. my things.
Yeah, unaware of the institutional beliefs. He was approached by a disability advocacy group, which challenged and hopefully challenged his understandings. Yes. And was there long-term follow-up with the children? Yes, the children, first of all, after this study, I don't know, Dr. Rubin, you're frozen. After this study, I hope everyone could hear me. After this study, it was only the following year when Geraldo Rivera exposed in his documentary, but it was Dr. Wilkins who actually worked in the facility, who was trying to get the parents and trying to get more funding. And the higher ups fired this physician. They fired him on the spot and he left. And Geraldo Rivera was actually a colleague of his, and he told Geraldo Rivera, and he had the clandestine key. He had the actual key to the building. So that's when he described what was going on there, and that's when they came in with the camera crew. And as far as the residents, my understanding, it took so many years to close, but they went into group homes, and some were actually abused in the group homes. Some of them were very unhappy there, but some of them, many were misdiagnosed. They were not mentally disabled. There was one gentleman who had cerebral palsy, and he's an advocate now for vulnerable populations, for the disabled.
Okay, that's okay. Peter, you're on. I suspect I was muted before. I'm sorry.
Thank you.
I shouldn't be on? Yeah.
Yes.
Sorry.
Go ahead, Peter.
Thank you, Bob. Thank you. I will bring that slide up. I'm trying to share the slide, so give me just a second. Can you see my slides, or I guess not? Dr. Rubin?
Yeah, not yet.
Not yet. Okay, fine. I will try again. All right. There it is. Yeah, so it's okay. You will get it now.
Success.
Okay.
I really have to say I appreciate everybody's patience with this. Sometimes these things run smoothly.
Yes. Thank you.
So we just all roll with it. Go ahead, Peter.
Thank you, Dr. Rubin. It is a pleasure to be back to the New York Academy. I'm a proud fellow of the institution, and this is my second appearance at History of Medicine nights after 12 years. Tonight, I'm just going to give some brief remarks on a phenomenon that is coming back to us after having a very long history, and that is therapeutic messianism. And I selected two examples of this, one related to heroin withdrawal, the treatment of heroin withdrawal, and another to the use of ivermectin for COVID-19 infection. I'm going to start with the problem of opioid dependence in New York City, because that's the place where I've been practicing for more than 40 years. And this has been a huge issue for certainly more than a century, and to the extent that the first place where drug addiction was treated was in Brooklyn at the Brooklyn Home for the Habitués, the place that was opened in 1891. And then just 10 years later, we have a note regarding the opening of the Charlestown Hospital for drug and alcoholic addiction. It opened on 82nd Street in Manhattan, and then it moved to 293 Central Park West, which is on 86th Street. And then in 1918, as everyone knows, the New York State Narcotic Drug Control Commission was created, and then the Harrison Act came about. There were arrests of doctors and pharmacists. And the first morphine maintenance clinic followed very quickly after that in 1919, and good solid research regarding drug addiction was pioneered in New York in 1925. Now, this is a rendition of Charlestown's Hospital. Back when it was new, and what it is today, the building is the same, it's just that it is now a residential building. It has been a residential building for more than 60 years, but the structure is there. And the hospital is celebrated particularly for its association with a physician by the name of Alexander Lambert, who was a professor of clinical medicine at Cornell, and was attending at Bellevue Hospital, like many people who worked at the time at Cornell had that job as well for the city. And this is a paper that was published in 1909 by Lambert, and it says the obliteration of the craving for narcotics. Now, back then, and very much like today, a medical article, an article in a medical journal gets to be really appreciated if New York Times talks about it. And here's what the New York Times had to say in just 2 weeks after the publication in JAMA. It says here, the announcement made by Dr. Alexander Lambert, visiting physician at Bellevue Hospital, that he has at last discovered a speedy cure for the drug habit and alcoholism, has aroused much public interest. Well, we don't know how they judge that. And it says that men of his profession are particularly interested, hopefully not only men. The fact that Dr. Lambert is a physician of high repute and recognized authority in the matter lends credence to his contention that the most confirmed drug addicts are not beyond cure. And says Dr. Lambert in New York Times, the obliteration of the craving for narcotics is not a matter of months or weeks, but it's accomplished in less than 5 days. The result is often so dramatic that one hesitates to believe it's possible. And the New York Times story goes on to say that the physician obtained a specific treatment some time before from this person, Charles Towns, who was actually an insurance agent, had absolutely no medical training, who had spent some years in China and had watched the treatment of opium cases among the hospitals there. I'm just going to have to say that there is no evidence that Towns had ever gone to China, and I doubt that he ever did. Since that time, he had experimenting with it extensively in his practice. Now, it's about Lambert, not Towns. And then there are some specifics that are being provided by the newspaper article, 15% tincture of belladonna, and the final, statement, the cure, according to Dr. Lambert, can be effected with a minimum of suffering, no matter how long the patient has been addicted to the habit or to what quantities he had been accustomed to take drugs. Now, this protocol was used continuously by Lambert and possibly many others, and it was published in the first edition of Cecil Textbook of Medicine by American authors. Russell Cecil was a colleague of Lambert's at Cornell and at Bellevue. And this textbook is a foundational reading for medical education in the United States since 1927 up to today. The last edition was published in 2020. So what was the treatment that Lambert was using for heroin withdrawal and heroin addiction, in fact? It starts with 6 drops of the belladonna mixture, and then you give this every hour for 6 hours, and then you increase it by a few drops every hour, again at 6-hour intervals, and you keep escalating the dose till the patient develops evidence of anticholinergic toxicity. Marked pupillary dilation, dryness of the mouth, rash, I'm sure changes in mental status. So at that point, the number of drops were cut down in half and then increased again by 2 drops every hour. It was a complex calculation that had to take place. And the treatment was continued for about 4.5 days. It was a specified number of administrations. Now, this approach has been first used by a physician in Tennessee, George Perry. He used doses large enough to induce delirium, to clean up the system. That was Perry's statement. And it seems that Towns had gotten the protocol from Perry or from somebody close to Perry. No scientific evidence has ever been provided to support this approach, although Lambert had published some observation on about 28 patients. There were certainly no controls and no dose-related changes in the protocol to compare, the effect. And all the successive editions of the textbook continued to endorse this treatment until 1947, when all of a sudden there was a new generation of addiction medicine practitioners who stated very clearly that methods of treatment that involve the use of anticholinergic, atropine, hyoscine, are not only irrational, but are also harmful and should not be used. And this is a position that really has not changed in the past 70 years. For all of us who treat these patients, we would never think of giving any of this kind of medication. So what was at work here? Because Lambert was very well known. He was Theodore Roosevelt's personal physician and hunting partner. He had an enormous practice in the city. He is just an example of many of therapeutic messianism. And this phenomenon of therapeutic messianism has essentially 4 components. It emerges in time of health crisis. There was an opioid epidemic back then. It builds on already existing practices or knowledge, more practices than knowledge, is suggested and supported by orthodox, but often heterodox physicians with recognized or self-proclaimed authority, and promotes accessible and affordable medications, but may involve high fee-for-service expenses. Now, the latest example of therapeutic messianism in the United States is the use of ivermectin for the treatment of acute COVID-19 infection. And this started in the summer of 2020 when ivermectin was prescribed in many countries, including the United States, but predominantly in South America, for prevention and treatment of acute infection. The rationale for treatment, for accepting the treatment, was never clear, and instead we have statements from the people responsible for introducing ivermectin in the treatment protocols, like, we do not have time to wait for scientific evidence. That's the Peru's, the country of Peru's health minister saying in May 2020. And another one in Bolivia who says, I'm putting it in the protocol, even though it does not have scientific validation in the treatment of coronavirus. Both actions are illogical, absurd, and yet they did happen. This antiparasite drug without antiviral properties in vivo was used purely on an empirical basis. And by the end of spring 2021, the drug was recommended in the United States based on the results of meta-analysis of studies that aggregated small sample or very flawed or possibly fake trials, all out of performed out of the United States. And yet groups of physicians in the United States published meta-analysis, which were definitely flawed because the input data, the primary data was clearly inappropriate for such an effort. The recommendation obviously was strongly rejected by the National Institute of Health and the Centers for Disease Control and Prevention, and this rejection has been continuing, is continuing to up to date. Now, since 2021, well-designed, appropriately blinded, randomized controlled trial, very large, performed in the US and elsewhere, indicated no beneficial effect for ivermectin. It just doesn't work for prevention, for treatment, or for what it's called now long COVID. However, once the ivermectin was used in the US for this problem, the number of calls to poison control centers may have increased. We don't have a total count, but it looks like it had increased. And some patients who were considered to have adverse effects of ivermectin administration required admission to the hospital, including an intensive care unit. Lack of effectiveness, potential for significant adverse reactions, support therapeutic restraints. Nonetheless, at least 400 physicians in the US, they are on record, there is a list of such doctors, continue to recommend ivermectin as a principal component of therapeutic protocols using multiple existing drugs and supplements. And here is just showing that a slide of many articles which now have related the use of ivermectin to political inclination or to political choices of patients and their physicians. And it's very, very clear. Physicians are in red and lay people are in green, that the use of ivermectin or the preference for ivermectin comes together for the two groups, and it's directly correlated with the decrease in the interest in vaccination, which is a very dangerous and worrisome issue at this point in time. So just to conclude, the off-label use of ivermectin for COVID-19 has been interpreted as an appeal to populism, offering a simple solution to a complex problem. And this position is compatible with the core feature of evangelical messianism, with the promise of salvation that will become reality after a long and hard battle. So who are the adversaries here? So the battle right now, in the case of therapeutic messianism, now ivermectin, is between the agents of the establishment, which are the experts, research institutions, high-ranking technocrats, mainstream media, the peer review system of good journals, and a large part of the population, versus the agents of change. Now, here we could include heterodox physicians, science skeptics, pay-to-play medical journals, some right-wing politicians, I could give names if anyone is interested, anti-elite media outlets, same thing, and their public. A problem is that therapeutic messianism has become a major challenge to science or evidence-based medicine and encourages patients to distrust most healthcare providers. Thanks.
Thank you very much, Peter. Nothing changes. There are no comments in the chat. And just perhaps one comment. You're a psychiatrist. What do you think makes people have belief in something which is just plain nonsense?
I think that the people have to be defined a little bit better. There are clearly people who do it for mercenary purposes, people who prescribe it, who sell it, who who do, who sell it as a package, including telehealth evaluations and others. So that we put that apart. There are also people who want to become relevant, and there are some doctors, I'll have to say, who have become relevant in, in this way. They're known. I mean, they're not relevant clinically. The main problem is with a patient population, and particularly with their families. Why would a family go to court to obtain ivermectin prescribed by a non-affiliated physicians for a moribund patient? I think it comes from desperation, and that's something that we can all agree motivates some people. But I think it also comes with the anti-elite feeling that has permeated the discourse in this country since 2016. I don't have to say more about 2016 to make myself understood.
Thank you very much. We've kind of run out of time, but our final presentation is by Robert Wieczorkowski. He is in Special Collections in the History of Medicine, George F. Smith Library of Health Sciences, Rutgers University Libraries. And his discussion is mapping, quotes, every death from preventable disease, unquote, in Newark, Dr. Edgar Holden's mortality and sanitary record of Newark, New Jersey from 1859 to 1879. Go ahead, Bob.
Thank you. Thank you, Dr. Rubin. I'm very grateful to the Academy for this opportunity to present at History Night. I last presented at History Night in February 2020 in person at the Academy. And afterwards, I went out to dinner with some medical history friends. I thought about that dinner a lot because that was the last time I went out to dinner with friends for about 1.5 years, as we were all living through medical history and epidemic history in real time. So I'd like to start my presentation by showing you a map. This is a map, quote, showing the locality of every death from preventable disease in the year 1872, showing also the state of the sewers for that year. Who created this map? Why was it created? And what exactly is preventable about the preventable diseases? That's what I'm going to be talking about tonight. This is the teaser. I'm going to switch screens again to show a little bit more. Great. Are we good? Okay. And here we are. I hope my presentation is showing. Okay. And before I go further, I'd like to mention my silent partner in this presentation. The background material on Dr. Holden and the motivation to digitize Holden's book came out of Dr. Sandra Moss's 2014 biography of Edgar Holden, which is really a thorough history of 19th century New Jersey physicians, medical practice, and medical institutions. I recommend this book highly. So here's Dr. Holden, right? Nice mustache. And here is his brief biography. He was born in Massachusetts in 1839, graduated Princeton in 1859. He then earned a medical degree from the College of Physicians and Surgeons in the city of New York, that's PNS, which is today Columbia's medical school. He graduated in 1861. He graduated right into the American Civil War and served as a naval surgeon for the Union. He served on ironclad warships and witnessed the famous battle between the Monitor and the Merrimack. He ended his military service in 1865, stationed as a physician at Ward's U.S. Military Hospital, or Ward Military Hospital, in Newark, a soldiers' hospital founded by Newark businessman and politician Marcus Ward. Holden then settled in Newark for the rest of his life and became one of the city's most respected physicians. Over the course of the rest of his life, he published over 40 articles and monographs. He devised a couple of medical devices, including a sort of a failed technology called the sphygmomograph, which was a graphical representation of the pulse. And then the main thing that he did career-wise in Newark was that he soon began working in the medical department of the Mutual Benefit Life Insurance Company. MBLIC was founded in Newark in 1845, and it was the first life insurance company in New Jersey and the fourth in the United States. In fact, they insured 4 presidents of the United States. Dr. Holden rose to the position of medical director at MBLIC in 1870, and he remained with the company right up until his death in 1909. So while at MBLIC, he published the volume that I'm discussing this evening. This volume has several different titles, but this is the sort of the official, the full title being Mortality and Sanitary Record of Newark, New Jersey, a report presented to the president and directors of the Mutual Benefit Life Insurance Company, January 1880. So what's inside this book, which is about 60 pages? It's a little oversized. It's quite a rare book. It was published again by an insurance company, not by a commercial publisher. I will note that the New York Academy of Medicine Library has a copy. So anyway, if you go into this book and you open it up, the first thing you will find is data. Holden was able to report data from Newark death certificates and apparently from some of the resources from his insurance company for most of the years between 1859 and 1879. And this is just a portion of one page that I'm showing. And if you look up at the left side, you'll notice the word zymotic before we get to the diseases below. Just to mention that this zymotic idea is sort of a disease concept moving towards germ theory, but not there yet. The idea was sort of that bad stuff, right? Bad air, bad water, bad food enters the body and undergoes a process, something like fermentation, which causes the particular diseases. It's sort of miasma theory moving toward germ theory. It's incorrect, but it was getting there. But what's important to note is that, first of all, these are infectious diseases. And again, you see chickenpox and cholera, diphtheria, glanders is mumps, hydrophobia is rabies, no cases, measles, smallpox, right? And Holden considers these preventable. And this is kind of a model advance. For those who've read Charles Rosenberg's classic cholera years, we're less than half a century away from considering epidemics as caused by God, right? And so he's again thinking that infectious disease, all infectious disease, is really preventable. So from data like the data that he's showing, and just to point out, for example, if my cursor's showing, that you see like there's quite a number of scarlet fever cases in 1860, 233, but really no cases of mumps. Really not a whole lot in the way of smallpox, 27 cases one year, 31 another, not too crazy. And what he then did was take the data and make ratios. Okay, so the first thing is ratio of deaths from all causes per 1,000. Okay, so this is all cause mortality. And again, you see the number between, starting in 1859 at 25, going to 30, down to 24, right? If this was interactive, I would ask people what they think the current all-cause mortality in the United States is, but I'll just give you the numbers. Converting it to from all causes per 1,000. In the US, it would be 7.2 in 2019, 8.3 in 2020, and about 8.8 in 2021, right? So an average year in Newark in 1860 was about 3 times worse than, for example, the brutal pandemic year with both the COVID and opioid pandemics essentially functioning. The third, I'll point out that, again, rate per 100 is really percentage. So the second column down is zymotic disease, right? So between 11 and 17 or so percent. The third line is the interesting one, which is rate for all preventable disease, roughly half, right? So he's talking about 48 to 53 or so. So that's what he's considering as preventable disease in Newark. He took his data, he took his ratios, and then he made these really beautiful charts. They're colorful, they're kind of striking to look at. This one again is covering the full period of the book, 1859 to 1878, in his data. I show this one up to show that the top line, the green line, is diseases of mothers and infants, right? We're still talking about maternal mortality and so on, and that rises again to 18% of deaths in the city. In 1866 and 1870, it tails off quite a bit. Holden does not explain what his thinking is on why this reduction. And then diseases of digestive systems, that's external causes, circulatory, and so on down the line. I'll show you one more chart. This is diphtheria, malaria, and smallpox. The top line, the purple, sort of-ish, the purple-violet, is diphtheria. You'll see there was really quite an epidemic in 1875 and 1876. 1875, the percentage there is 111 out of 1,000 deaths in Newark, right? So basically 11% of all deaths in Newark were diphtheria in 1875. Malarial diseases jump around in the middle, but kind of stay sort of there. And the bottom is the black is smallpox. So you again see that there's outbreaks in 1872, 1873, where it sort of rises up. But other than that, not a giant factor there. So then moving along, he's got his data, he's got his ratios, he's got his charts, and Holden begins to think environmentally and think geographically. And what he begins to do is analyze the data by ward. Newark at the time had 15 wards, and he begins constructing kind of graphic representations of the data in a geographic sense. So I just picked this page because he's using the 2 years, 1872 and 1876, which are particularly high years for mortality in Newark. the top section, diarrheal diseases, you see a lot of red lines, and then the black lines below are shorter, meaning there was much more diarrheal disease in 1872 than 1876. Conversely, underneath is one of those diphtheria years where the red lines are fairly small and then the black lines rise up. And he starts to begin to think of it in a geographic sense, basically. And from all of this, from all of his data, we wind up with maps. And that's the map I showed you at the beginning. There's 4 maps in the book. Map A showing preventable disease deaths in 1872. The second map is 1876. The third is sewers, and the fourth is a topographical map. If anyone is interested in the modern field of GIS, this is going to be a wonderful project to kind of pack these together. Again, I throw that out there. I consider this sort of a document or a volume in search of scholars. And I want to take a closer look at one portion of the map. This is sort of centered on Broad Street and Market Street, for those of you that know Newark, the 4 corners, if you will. This is zooming in quite a bit. And if you can see my cursor, that's a military park, right? So if you've ever been to NJPAC, that's on that corner, or the New Jersey Historical Society. Over here is Washington Park, right, where the Newark Museum of Art is located. A little over here is the Newark Public Library, and so on. I want to point one more thing out while you're looking at this map, and while you're looking again, each black dot is representing one of Holden's deaths that he is geographically located. This body of water over here is the Passaic River. And if you look, you'll see this kind of grayish body of water line that goes down and comes into the river. Today, that's Raymond Boulevard, one of the major streets through Newark. At the time, that was the Morris Canal. And so this is a map of, again, what Newark was like, where things were in 1872 and where people were dying. He used these sort of areas where he seemed to see pockets of exceptional mortality and kind of encircled them on both the 1872 and 1876 maps to sort of show a comparison between the 2 years. So now we come to the eternal question. So what? What did this add up to for Holden when he completed his report, when he filed all his data and created these maps and so on? And in fact, Holden did come to a conclusion about a particular element of the infrastructure that did have an impact. And in fact, he did something that's quite admirable. He looked at all his data and he changed his mind. And so now I'd like to share with you one longish quote from later in this book from Holden. He says, "From the location and direction of the sewers, the change wrought by their introduction seems to be favorable rather than, as many have asserted, unfavorable. Indeed, my own conviction prior to this investigation was that the sewers were a source of increased mortality, a conviction which does not appear to be justified by facts. The canal, too, which is but too truly an open sewer, would, according to theory, seem a source of disease, does not show such an assemblage of black marks in its vicinity as to warrant present apprehension, although it needs no argument to show the danger of its too frequent use as a drain for the population along its banks." And so the result of Holden writing this report in 1880 is significant, actually. In his 1988 book, Newark, the Nation's Unhealthiest City, 1832 to 1895, historian Stuart Galashoff credited Holden's book with providing a quantitative demonstration of Newark's poor record in public health and sanitation, and providing a boost to municipal sewer construction. And that, again, is as a result of Holden looking at his data and changing his mind. And so I'd like to finish up by, again, suggesting that this is a document, a volume in search of scholars. Get in touch with me if you know anybody who's interested in history of epidemiology, history of GIS. I consider this sort of a proto-GIS. History of bacteriology, if you want to investigate the zymotic theory further, or local history in general, if you're into Newark at all. And I'd like to point out that there's a volume at the New York Academy of Medicine. There's a scanned volume on archive.org. That's the National Library of Medicine's copy. And then there's the copy that comes from my special collections, which is Holden's personal copy. It's signed by both him and later his wife. That's available on RU Core. And what I'll point out also is that the 4 maps, we scan them extremely high resolution. The average archival sort of standard is 600 DPI. And the maps are scanned. I think we did it either 12 or 1400 DPI. We went up to where it wouldn't crash the program. So we have some interesting material there, and you can come and locate all this material freely available on RU Core. And with that, I thank you, and I'm happy to take any questions if there are any questions.
Thank you very much, Robert. Really, a real contribution. We have a comment and a question from Arlene Shaner to everyone. Quotes, I'm interested in the way this report intersects with the 1865 Citizens Sanitary Association report in New York City that prompted the passage of the legislation that brought us the Metropolitan Board of Health. Does Holden mention that report at all? Question mark.
To the best of my knowledge, no. I'd have to read it over again to guarantee that. But this is essentially an internal report for both an insurance company, but for also Newark civic leaders. So it's an interesting argument. He's not actually, it doesn't come across as a truly public health argument. I think he's making an infrastructure argument in many ways and a local development argument. But that's a great question, Arlene. And again, when I was just double checking what years cholera years was covering, the third section is 1866. And I was thinking, oh yeah, I should read that again and see how it matches up to what Holden was doing. So thank you, Arlene, for that. Thank you.
One other comment from Elena R. Are there any major differences between zymatic theory and messianic theory?
Sure. Miasma theory, right? I see this. I'm not an expert in this. Again, I think there's plenty of people who study the adoption of germ theory. It took a while, right? It came in bits and pieces. I think this is approaching that because at least it's arguing like that there's a stuff that's causing it, and sort of a particular stuff. Whereas the miasmic theory is just like, well, this is the swampy water and everything else, and of course you're going to get sick if you live near here. I'm not an expert on any of that. And again, I think miasmic theory, has a much longer history. I want to say that the zymatic, I'm sorry, I'm looking at your word now. I don't know if I have the right word in my head, is sort of a mid-19th century, maybe a slightly quote unquote scientific upgrading of miasma theory or malair or whatever you want to look at there.
One final question from Bill Summers. Did he argue that insurance rates be adjusted by location?
So that's an absolutely fascinating question. And I would say Sandra Moss's book is listed as a biography, but it's not. It's more than that. And one of the chapters she has is essentially a history of insurance medicine in America. And if you think about the idea of insuring somebody's life, what are you basing that on, right? I mean, one of Holden's, this device that he creates, the sphygmograph, is sort of superseded by the sphygmomanometer, right? The blood pressure cuff. You can't even take people's blood pressure, and you're trying to write insurance policies for people. So I think there's maybe more going on, or this is an understudied area of medical history, is how exactly would you go about trying to determine the risk or the life insurance risk in a time with incredible infectious diseases, and again, all-cause mortality 3 times greater than today's. So Holden does not talk about insurance rates, but I feel like in the context of talking about the development of the city of Newark, he may be pointing out where people live in areas where fewer people are dying. So I wouldn't be surprised if the mutual benefit life insurance company was reading it with different eyes than Dr. Holden was presenting it in a way. I think the topic, though, in general of 19th century insurance medicine is a fascinating one. I would refer you to Sandra's book for more information.
Thank you very much. I'd like to thank all the panelists for really stupendous evening. And I'd like to remind everybody that the second session of this 14th annual will occur at 5 o'clock on Monday, the 24th of April of this year. And we have 4 presentations from Dr. Racy, the nasogenital reflex, impudence of the past as a lesson for a wiser future, from Dr. Fisher, Osler's deadliest diagnosis, from Dr. Levine, Jewish presence in the Fabrica of Vesalius, and from Dr. Spielman, John Greenwood's side notes on the 1778 John Hunter text, and Arlene Shaner is also a co-author of that article. I'd like to thank you all for really a very stimulating and wonderful evening. Enjoy the weekend, have a pleasant April, and we hope to see you all back on Monday, the 24th of April at 5 p.m. Thank you. Good night.